Hello, good afternoon, everyone, and thank you very much to BIOS for asking us to present this session on fracture-related infection. It's obviously a very, very important topic, and it's often quite a challenging problem. So I think that the upcoming speakers will present us with some very interesting cases that we can look at and learn some lessons from. So we will start with Professor Deborah Eastwood, who, as you will all know, is the Vice President-elect of the BOA, and she's an honorary professor at UCL. And I will let Deborah take over now. She's going to talk to you about bone and joint sepsis in children. Deborah, thank you.
Thank you, Deepa, and always a pleasure to be part of this BIOS meeting. So I'm going to talk to you about musculoskeletal infection in children, an old enemy with perhaps a new bite. If we're talking about the limping child in this webinar, we're talking about sepsis until proven otherwise, but sepsis of what? The bone, the joint, or the soft tissues? And either of those infections can be primary or secondary. So one of the big questions is the joint swelling reactive to the nearby osteomyelitis, or truly an infective process in its own right? So let's take Alice, aged 15 months, had chickenpox a few days ago, and has now presented with pain and a limp, for which she was prescribed trimethoprim for a UTI, a little odd you might suggest. 4 days later, and perhaps not surprisingly, she's worse, with a temperature, white cell count, ESR, all raised. They phoned me on the Friday afternoon, as they often do, with an ultrasound scan, which showed a significant amount of fluid in the right hip, with the arrows there, compared to the left hip. I was told over the phone that the X-ray was normal, that she'd been treated for DDH, well, she'd been observed for DDH in the past, and the X-ray was normal. Mistake number one was she came over to me without the X-ray, and I took her to theatre based on the clinical examination and the ultrasound findings. Now, was it infection? Well, transient synovitis is just like sepsis, but qualitatively different. And it is not a diagnosis that you can make in those under 2. So although Cocker's criteria and Caird's amendment, which is the CRP, are very important, whatever they say, do not diagnose transient synovitis in Alice, who's aged 15 months. So she had clinically and on ultrasound a septic arthritis. So the question is, do I drain this with a needle, with an arthroscope, or do I open the joint up? Whatever you do, you have to wash the joint out well. The hip joint on the whole is a joint that we would open up via an arthrotomy. So I did a medial approach to aspirate, and I got pus. So then I did an anterior approach to open up the joint. You must treat your specimens carefully and ask the correct questions. And I took an X-ray on table because I hadn't actually seen her X-ray. And in the frog leg position, her hips were well located. We grew from her, because this is a few years ago, we grew Haemophilus influenzae, which we are not supposed to grow now because of children having a vaccine against this. But if you ask and take a good history, she didn't have the vaccine due to frequent coughs and colds. So always make sure you've taken a full history. Currently, the bug of the day is Kingella kingii. So a 2-year-old now would have Kingella kingii until proven otherwise. We treated her with antibiotics. By day 7, she was generally much, much better, but did seem to have a local collection confirmed on ultrasound scan and an X-ray that was bad. So there's the collection that we did go back and drain on the superficial side, and then we had to deal with her subluxed hip. This was predictable and avoidable had I actually seen beforehand the initial X-ray from St. Elsewhere's instead of the frog lateral view that I did in theatre myself. So we drained her abscess, the hip was looking good, we stabilized her in a spica cast, which we should have done perhaps initially, and she had her PICC line in place. There is an ongoing debate about the duration and method of administration of antibiotics. So this child continued with a pyrexia low grade and a raised white cell count, but she was really very well. And eventually I persuaded the microbiologist that we should stop her IV antibiotics, and she got better instantly. She did in fact have a hypersensitivity reaction to the antibiotics as judged by her eosinophilia as a cause for her raised white count rather than really a neutrophilia. And a recent paper suggested that PICC lines in children may be troublesome and in fact more trouble than they are worth. So we have to find a way of treating her with antibiotics without the hassle factor of prolonged antibiotics unnecessarily and PICC lines. So this Finnish study from a little while ago now, but it's still very valuable, says that for a primary septic arthritis, pus in the joint, the duration of treatment in total is probably only 2 weeks, providing the clinical response is good once you've popped the abscess and the CRP has normalized. So IV to oral promptly following drainage within 2 to 3 days. So no need for your PICC line. But if we do need to keep a PICC line in place, we now have outpatient antibiotic teams that will allow that to happen. Is my septic arthritis of the hip in a neonate or a young child primary or secondary? And there's a question about whether all children should have a preoperative MRI to have a look to see for a focus of osteomyelitis. So this paper suggested that you looked at 5 factors, and if you had 3 of them, there was a high risk for an osteomyelitis as the cause of your secondary septic arthritis. And the more recent paper with Dave Skaggs as an author suggests that if the child has had symptoms for more than 4 days, that would be very suggestive of osteomyelitis. So young Alice fell into that category, but actually had no osteomyelitis present. What she did go on to develop was avascular necrosis because of the delayed drainage of her septic hip. Predictable, but thankfully recoverable because nature is a marvelous thing. And she is now skeletally mature with a no leg length difference and a good quality hip, but not quite perfect. But there are atypical cases of infection in children. There are odd bugs. Young Daniel had a history of chickenpox again with ankle pain and swelling, which was aspirated and grew nothing. So for a long time, he was treated as a juvenile inflammatory arthritis with steroid injections and disease-modifying drugs. This X-ray at 12 months was considered okay, and I hope that we would disagree with that assessment. 3 years after the onset, was referred to the orthopedic surgeons with an obvious soft tissue infection. We incised and drained it and got no growth. And there were continued discharges and several trips to theatre, to the extent that I was beginning to think that the fellows had no idea how to drain an abscess. But we took good specimens, and in the end, we stabilized the situation with an external fixator, did a wide debridement of the infected tissue, which included the distal tibial epiphysis and the talus, and we stabilized the bone and, if you like, the pseudo joint. Multiple dressing changes. And why did we have such difficulty? Because this child had Mycobacterium kansasii. I'm not expecting you to remember the bug. I'm expecting you to remember that when things don't fit together, start asking yourself why. And again, you have to make sure that you take samples and deal with the samples carefully and discuss in a multidisciplinary team manner with your infectious diseases colleagues and your microbiologists. 4 years on, the child does have a leg length discrepancy as expected, some pain, and the foot shape is not good. But an amazing amount of bone has regrown, considering I thought I'd taken it all out. What I think I did was leave a small shell of the talus behind, and I didn't actually see the clean cartilage of perhaps the talonavicular joint. So my learning point is that I did a good debridement, but maybe thankfully I left some bone there by mistake, if you like, which turned out to be a good thing and helped the end of the case. And they're going to have a lengthening nail to treat their leg length discrepancy. Yara had sickle cell anemia. So we always think of Salmonella osteomyelitis, but Staph aureus is by far the most common infecting organism. And again, we want to know these days whether it's got a PVL positive or negative aspect to that. So this child had a septic hip and aseptic osteomyelitis of the tibia. Required multiple surgical procedures again, with problems with nutrition, problems with splintage to keep her comfortable and well aligned. And the future is predictable again, that there will be abnormal growth of the hip and of the tibia. So by 15, we'd corrected her overgrown and long right leg, and there's very little evidence of her previous tibial infection there. She has a bad hip and a short leg, so she wanted a new hip because it was uncomfortable. She had a new hip, and she remains unhappy because no one told her that her leg length difference would still persist. So she's got a good hip, but she's still got a short leg, and it makes you realize that perhaps it's the short leg that was causing her more problems than her hip. She'd also been labeled as having multiple recurrent infections because she'd had such a bad start to life. But in fact, there was never any evidence of multiple infections after the first bout. They were just sickle cell crises. So it's difficult to know whether you're dealing with infection or crises. So in osteomyelitis, why do we need to discuss something about osteomyelitis? Well, in general, one of the interesting things is we love to culture fluids. All of these fluids we culture, and discharging mucky wounds we culture. But we don't culture bone. So if the infection is in bone, we think, okay, we don't need to culture it. Maybe just because all the other samples can be taken without a general anesthetic, but the bone would require an anesthetic or at least some substantial pain relief. And so if it is an infection, an osteomyelitis, which is complicated, so it's either gone in through the bone and into the subperiosteal space, or it's gone through the bone and into the joint, that's when you can and should get samples for culture and sensitivity. But if it's an acute, uncomplicated osteomyelitis, there is no pus to drain and no pus to sample. Yes, you could aspirate the cancellous bone, and yes, you might grow something, but on the whole, we tend not to do that. So we reserve the biopsy in osteomyelitis to exclude malignancy, or maybe to identify the specific bugs in the atypical case, which I mentioned earlier. So again, in acute osteomyelitis, uncomplicated, the Finns feel that the probable duration of treatment is again shorter than many places would instigate. So 3 weeks in total, with again a prompt change from IV to oral, assuming the child is responding well to treatment and guided by the CRP level. And of course, exactly which antibiotics you give must be guided by local policies and local prevalences of infection. Infection of the muscle, pyomyositis, is much more common these days, or much more commonly recognized. It's associated with the PVL positive community-acquired MRSA, and a few years ago, every children's hospital would have a case about every month. Now it's perhaps not so frequent. Strep pyogenes can give you the same sort of appearance. It commonly affects the thigh, the pelvis, with a very high ESR and a very high temperature and positive blood cultures. The diagnosis is often on MRI with patchy, small abscesses in many of the muscles, but I mean small, maybe 2 or 3 millimeter abscesses, so not easy to identify via interventional radiology or the surgical knife. But if it is a PVL positive infection, it is more likely to require surgical drainage. And by that, I mean also drainage by the interventional radiology team, leaving a catheter in place. At the other end of the spectrum, there's this lesion, classically in the medial clavicle, with the chronic, relapsing or recurrent multifocal osteomyelitis, or what we now tend to call as chronic non-bacterial osteitis, because that's exactly what it is, non-bacterial osteitis. This is an autoinflammatory, not an autoimmune condition, and it's certainly not an infection. So this is in a different category altogether, but it might bring you to think about differential diagnoses. And if we're going to talk about differential diagnosis of a child with sepsis, for example, this child at 4 weeks had 2 weeks of symptoms, so was referred as a nerve injury and a possible brachial plexus problem, which shouldn't really have started 2 weeks after birth. So always think fracture, always think infection. So the child did not have a fracture of the clavicle, but did have a subacute osteomyelitis of the proximal humerus. If you're going to think infection, think tumor. And in the limping child, although we've been thinking infection, please always exclude trauma. And once you've excluded trauma, you should always think tumor. This child was running around happily when I was asked to see them with their, quote, rampant, unquote, osteomyelitis. By examining the abdomen, we found the mass, which was the primary neuroblastoma, and the secondary deposit in the femoral neck was a tumor, of course. So think tumor, think infection. And when you're thinking infection, think acute, subacute, or chronic. And if you're thinking that, then also just occasionally think of your CRMO. Thank you very much.
Thank you, Deborah. That was absolutely fascinating. I must say, I mean, childhood infection really is fascinating. The term the great mimic has been used for many different diseases like syphilis and tuberculosis. But really, I have to say, in kids, infection really is a mimic. I think we will leave questions until the end, if that's okay. So our next speaker is Mr. Badri Narayan. Badri, if you could start sharing your screen. So Badri is a consultant orthopedic surgeon in Liverpool, and he obviously has a specialist interest in infection and limb reconstruction. Badri also has a huge educational commitment. He's been on the committee of the British Limb Reconstruction Society. He's been a member of the SAC, and he's also an examiner. Thank you, Badri.
Thank you, Deepa. Thank you, Amit, for the invitation. This is going to be a huge step down from the intellectual to the very mundane problems of what happens when things just don't go too well with fracture fixation. I'm going to be covering a few issues with a few cases, and then Om, following me, is going to talk about the reconstructive options. Oops, that's my advance. Yeah, there it is. A few declarations of interest, none of which are relevant to the cases I'm going to show. All these cases are from my hospital. I'm not picking anybody else's cases to show. And all these have been under my care in the last 2 or 3 months. So here's case one. This chap is in his 50s and he has a closed fracture of the humerus. He has an attempt at non-operative management, doesn't work. He then has a classic anterolateral approach with a lag screw and internal fixation. And this is a representative picture of him coming to clinic, but this is a screenshot of the clinic letter. Seen in clinic, has a sinus, blood's okay, we're not too sure. Currently, he feels okay. He's just reported the sinus. Let's just see him again. And he goes through this orthopedic cycle of being seen at 6 weeks and at 3 months. He says, listen, there's a wound that leaks, but I'm okay. People say, come back. Let's see what happens if you become really unwell. And this is him at about 12 months after the injury, referred for a full-blown infected non-union of the humerus that needs 2-stage reconstruction. Here's another case from my own hospital. This was a more challenging internal fixation in a woman in her 50s. A bicondylar fracture has been fixed with 4 plates. She goes on to be discharged. She comes back to clinic, and this is a tertiary referral. So she comes back to the orthopedic clinic at about 6 weeks, and that's a screenshot of the clinic letter. I understand she's been on flucloxacillin because she developed redness or the anterior aspect of her leg. So what happens then? She's told, continue the fluclox for a few more weeks and we'll see you back. She comes back at about 4 or 5 months, and it says, had recent signs of cellulitis and inflammation, but these were settled completely through several courses of flucloxacillin. And you know what's going to happen next, right? suppress for another 3 months, and then we'll remove the plates when the fracture heals, and we'll see how you get on. And this is 30 months after the initial trauma, with full-blown raging osteomyelitis that is not settled after removal of the plates and screws. And she now needs a medial gastroc flap and very aggressive debridement of her osteomyelitis. And now here's another case. And those of you who've been actually paying attention will recognize that this is the same clinical photo. And in fact, the clinical photo that I showed of the arm was actually this patient. Look at this for a change. Same hospital. Here's a blue spear documented MDT discussion of somebody who has a post-op infection, admitted because the wound looks a bit dodgy at 2 weeks, CRP done, but people are concerned that the patient is not improving. Now, why is this so different compared to the other two? The age of the patient is the same, in her mid-50s. She has a similar wound compared to the first two, which were treated with flucloxacillin. It's only because this is an infected joint replacement and people's alarm bells are ringing and everybody is going crazy about a wound that doesn't look quite right. Why are we treating such similar presentations so differently? The patients are the same. The organisms are likely to be the same. The pattern of formation of the biofilm is likely to be the same. The treatment is established for a prosthetic joint infection, which is do not start antibiotics, aspirate if possible, get deep samples, and then decide whether you want to do a debridement and implant retention. Fracture-related infection costs a lot of money to treat. It costs at the minimum about 4 times the amount of money to treat a fracture-related infection as it does to treat a simple fracture or a simple non-union. We can't avoid fracture-related infection, but we can mitigate the enormous burden to a healthcare service by early and appropriate management of fracture-related infection, of early and appropriate management of suspected fracture-related infection, by following some simple guidelines just as you have in the arthroplasty world. What are these guidelines? The BOA came up with these guidelines about 18 months ago, and these are fairly simple. They are in many ways the same as the arthroplasty guidelines. If you have a problem wound before it's healed, you want a consultant level urgent review within 24 to 48 hours. If you have a problem with the wound, ideally in your discharge letter, the patient should know, or the GP should know what to do with the wound. There should be a referral pattern available for the GP or the patient to seek advice. If you see somebody with a problem wound, you should have a defined MDT management, including radiology and microbiology for the management of these patients. What does that involve? It can involve something as simple as an urgent deep ultrasound to check whether the collection is deep or whether it's superficial. Based on it, what should we do? This is not beyond our level as orthopedic surgeons. If the collection is deep, we've got to drain it. And while we're there, we should look for the stability of the fixation. If it's unstable, if it's a distal locking screw that's backing out at 4 weeks, there's no point trying to imagine that this is stable fixation. It's going to fail. We've got to look at the soft tissues and assess whether the soft tissues are amenable to tension-free closure with a 3/0 nylon or a 3/0 monocryl. It's not, it's particularly around the ankle and the anterior pilons and the proximal tibia, you're more likely than not to fail. You've got to have multiple samples, and we've got to have deep samples to check whether these are susceptible organisms or whether they are resistant organisms. And based on these three, stability of fixation, status of the soft tissues, and the pattern of bugs, we can then decide whether we can suppress the infection or whether we need to revise. Suppression will work about 50 to 60% of the time, depending on how you define your outcome. If your outcome is defined as, hey, I've got this fracture to heal, suppression works more than 80% of the time. The problem is you may then be left with osteomyelitis. So it all depends on how you define your outcomes. But if you're to suppress, be careful in these scenarios. So this is a chapter from the standards for the open fractures, but that's a QR code to the specific chapter on infection suppression. And this is extensively referenced. So in summary, if you have fracture instability, if you have an iron nail, if you have compromised soft tissues, if you have a poor host, if you have difficult organisms, try to avoid suppression, because the chances are you're not going to work. It's not going to work. It's not going to work. If you have somebody with the MEPO, do not try to simply debride the entry wound and the exit wound of your plates. A debridement means that you need to open the entirety of the plate and wash it out by connecting all the wounds, rather than trying to do minimal suppression by just washing out the entry wound of the plate and then landing up with a big problem that needs a big debridement. So debride and wash out, but make sure that the entirety of your plate is seen and access for you to clean it up. If you can't suppress, if you think you want to do an acute exchange of implants, this will work particularly in the upper limb. It will work particularly if you have plates covered with good soft tissues. It will work if you have susceptible organisms, typically your staph that's sensitive to multiple or antibiotics, but it's unlikely to work if it's a B host. It's unlikely to work if you have hospital-acquired organisms like enterococci, pseudomonas, Klebsiella, and all the nasty bugs from the escape group of organisms. If you're trying to do an acute intraoperative exchange, simple common sense things work, like take out the original implants, give the bone a clean, assess the stability, re-prep, re-drape, and start afresh, and keep the patient on IV or oral antibiotics for at least 7 days until your extended cultures come back. This is where it gets a bit sticky. This is coming to the end of my talk. This is what the guidelines say, that if you fail in your treatment, you need a defined referral pathway within your trauma network for failure progress. So if you've tried suppression, if you've tried acute revision, and if it fails, you need a referral pathway. And that should be aligned with your orthoplastic network. There should be a regional bone infection unit that takes these patients for you within a few days. And that can be almost dismissed by the thousands of us, in peripheral hospitals, ivory tower thinking, saying this is impossible to achieve, and it's challenging in the real world to get bone infection units to take these patients within a few days of us calling them. But you have to remember that we have come on a long way, particularly in the last 10 years as an association. And if you can imagine people with major trauma, etc., 10 years ago being taken to peripheral hospitals, now being shipped directly to bigger units directly, I think it's worth us pursuing this as an organization, because as our current president said in an editorial, identifying problems in the delivery of care should stimulate progress towards delivery of care and not entrenched thinking, saying this is what I've done and this is the way I'll be doing it. So in summary, these are the BOA guidelines for the management of acute fracture-related issues. You should have a policy for the management of the problem. If there is a problem, you should ideally have consultant level review of the patient within 24 to 48 hours. You should at least have facilities for an urgent ultrasound for these patients to check whether your infection is deep or whether it's superficial. Please, based on the guidelines, based on the patient host, based on the type of implants you have, consider suppression or revision, and every network should have a good defined pathway for failure of these patients to progress with suppression or revision in the treating hospital. Many thanks for your attention.
Thank you very much, Badri. That was really interesting. And certainly for the trainees in the audience, I would urge you to read the fracture-related infection boast, because certainly you will come across it somewhere in your exam. So we'll move on to our final speaker, Mr. Om Lahoti. Om, if you could start sharing your screen. Om is a consultant orthopedic surgeon in King's College, London, and a specialist in bone infection and limb reconstruction. Thank you, Om. He's also the current president of the British Limb Reconstruction Society.
Thank you, Deepa, and thank you, BIOS, for giving me this opportunity. Because we're running short of time, I will probably skip through some of the slides, but there will be some repetition. Oh. Can you see my screen? Hello?
Yes, we can see. Thanks.
Yeah. Okay. So you've seen these numbers and the burden of fracture-related infections. I won't dwell on it. I'll move on. And these cases which I'm going to discuss, we decided beforehand that case-based discussion would be more useful. So I'll go through the details. But these are all the principles which Badri has nicely outlined, so I wouldn't dwell on it. But I'll show you some cases to just how we plan it. Okay, there are many ways of incorporating all the principles you have heard and all the methods of investigation. And I find this a little classification, although it's not well tested, but it gives the outlines of how to deal with this. These are ICS approach. It's a framework of management I tend to follow in my practice. So is there infection? Yes, there is infection with all the signs. And is that early or late? Why do you differentiate between early and late? Early is within first 2 weeks, and late could be anywhere up to 4 to 6 weeks. And that's the difference is biofilm. In early, there is not enough time for biofilm to form, so you can still suppress, so-called DIR approach. Whereas when it becomes late, the biofilm has formed and implant is probably causing first osteitis and probably osteomyelitis. Okay, then callus. Callus is hearing. Is the construct stable or the bone making any attempt to heal? So that's another factor you have to throw in. And then, of course, the stability of the implant. Is the implant holding it, doing the job, or is doing the damage? Intramedullary nails go from entry point right the way down to the rest of the bone and can cause trouble. So that's the framework, and we'll go through that. And that gives rise to that ICS framework gives rise to these three sort of scenarios. Early infection, callus is seen or progressing, stable implant. Yes, you can go for maybe local debridement, superficial, give antibiotics, and retain until the fracture heals. But you should be prepared to change your tack anywhere. So this is where the consultant and the team should closely follow the patient and not leave it to anyone on the team. It should be consultant-led. And when the callus is non-progressive, here is a problem. You're watching, this is a common problem or common issue. You say, well, infection is not that rampant. Callus might form and the implant is stable. And again, here you could use some of these techniques to improve, particularly host physiology. But more importantly, in my tertiary practice, I get these infection, no callus, unstable fixation, and of course, all those signs of failing implant and failing bone, and sometimes failing patient. They've lost the patients. Okay, here is a story of a 30-year-old who fell off a ladder, peel on lower tibial. There were lots of blisters, skin very compromised, span and plan. After fracture blisters settled down, patient was taken twice to theater to have plates all around the tibia. But the wound broke down as soon as they closed the wound, literally. So it's an early case of early infection. So here is the sequence. The lower tibia, the skin was just, compromised here. It got better. And then first this plate was applied. And for some reason, the consultant thought they should go and do some more reconstruction and put that plate on. And soon after, we saw this, and that's when he was sent. So here is a situation where the implant is stable. It's early infection. Is pretty much clinically localized to the medial side. Lateral side looks good. So here I took an approach of, limited debridement, took out the medial plate, gave him IV antibiotics, and the construction was stable. So followed him up carefully, and here is his healing. And then we took out the implant. Then you should treat them with follow-up antibiotics to treat any residual infection like osteomyelitis through the screw holes. So that went on to heal with DIR approach. So the next case is, it just shows what all Badri had been saying. So this is a 23-year-old male with this kind of fracture, isolated injury, non-smoker, reasonably in good health, and had this fixation. So he went on to have an IM nail 3 days later. I looked at the operation note. It took them 4 hours, and they really struggled and somehow bailed out. And here it is. So he wasn't really happy. There was a lot of swelling. He wasn't feeling good, and he started having trouble. Somebody should have really started looking at, this is a difficult injury, and there's a high risk of deep infection. But all along, he was being treated for, he has never had an issue with his surgical wounds. That's what the word it said, but he was in a lot of pain and thigh was swelling. Then soon after, he formed a thigh abscess. I thought it would have just occurred to the treating team that it is much more than superficial infection. See, they again did the ultrasound. I don't know how they got to that, and just said it was superficial. And this was drained in theater, or they went on to say, well, this is superficial infection, give him antibiotic. So that's his sinus. Soon after abscess drainage, there was somewhere else, and then he started forming sinuses through those surgical wounds of locking sites. Okay, then further abscess formed. Again, they were holding on to him. They said, well, take oral antibiotics, etc. And then another dose of antibiotics, sinus more proximal, getting a lot of pain. And then they started worrying about no callus progression. This looked like a sequestrum, and that's when the CT scan and everything happened. That's when he was sent to us, and that was during COVID time. And ideally, they should follow implant removal, debridement, maybe single or 2-stage treatment. So he had all the signs, and for trainees to just say confirmatory signs and suggested criteria, you can read up, but he had all the signs. Okay, so can we predict the treatment in these cases? So I suggest you look up a BACH classification that divides the infection risk to straightforward infection to complex and no treatment option. So here it is. So uncomplicated is one group, complex, limited depending upon BACH, that is bone involvement, antimicrobial options, coverage by soft tissues, and host status. This is a good classification and a good good framework to work out whether there's a limited option or a complex treatment which is going to need 1 or 2 stages, or simply DAR would work. So in this patient, is segmental infection without joint involvement. So intramedullary nail is treated as B2, so that's the most severe of this classification stage, and the rest of them were reasonable. Is isolated staph aureus, which was sensitive to antibiotic. So during COVID, access to specialist center was limited, so that delayed the treatment, which didn't help. Anyway, I had to go to the other hospital and do a 2-stage. I would have otherwise done single stage, but I had to do 2-stage. So first stage involved taking the nail out, draining it, taking the sequestrum or as much dead bone as possible, and fix it with an intramedullary nail. Don't leave it without stabilization on a pin traction. It doesn't do patient any good. And to add further stability, I added just an external fixator, specific IV antibiotics, follow it up with CRP. And as Badri said, this is no mean exposure. This is just a thorough debridement. This is second stage after 3 weeks, or 4th week when CRP was coming down, wounds were looking good. You could prolong this one of the 2 weeks, but I was very happy with all the developments. So here is a problem. Whether you go back and put an intramedullary nail, some would say that, but if you see the preoperative or pre-treatment X-ray, there was deformity and there was gap in spite of the nail in that position. So you have to address not only the infection, create stability and an environment where biology will help this fracture. So local antibiotic delivery, intravenous antibiotics, and a stable construct without violating the marrow again. And a follow-up, that is the timeline. If you see, it started sometime in January, and now it is June. So I saw him last, and he started healing. And what is forgotten about this is that sort of delay caused a lot of stiffness of the knee. Quadriceps was adherent. He could barely flex 30 degrees. But once we stabilized him, got the fracture going, fortunately, knee recovered. So, we tend to forget the function in these chronic infections. And it's very important to take that on board, because that is the single most factor which affects the quality of life, not just how well your implant is holding or how well it healed. Here's a story again of a case where we are lulled by a little bit of wound infection, a little bit of wound discharge. So there's a 40-year-old involved in motor vehicle accident, multiple injuries. He's a smoker, and he had a medial wound on the proximal third of the tibia at the fracture level, so it was just debrided.
Yeah. Don't panic, but the lights are going to go down.
Okay.
Just for effect.
So
it'll be like, thank you, and then the lights
I think someone just needs to turn their mic off, if that's okay. Thank you.
Yeah. Okay. So that's a non-union infected non-union with the intramedullary. This is a different beast. There is a lot of bone, devitalized bone, and that definitely involves segmental excision and circular frame and acute shortening, because this fellow was not fit for plastic surgery. So we had to do all that using a circular frame. So that is frame, acute shortening with nearly 4 centimeters or 3.5 centimeter excision of bone, acute shortening on table, and bifocal treatment with distal lengthening, because it was very close to the proximal metaphysis. I couldn't have lengthened there. So that's his final function. Again, I just emphasize on this function is very important for limb recon surgeons or any orthopedic surgeon dealing with this problem to get in there to maintain function. We can control bone infection with clever antibiotics and other things, but if you start losing joint function, that has a very adverse effect on quality of life. So in a quick sort of wrap up, the fracture-related infection ranges from uncomplicated to very complicated, and BACH classification clearly outlines this at the very beginning. So you can advise the patient, create all resources, and maybe decide an early amputation or something on those lines. So try and get access to specialist centers if you're not in a specialist center. I have a liaison service, and it can be a single stage or two-stage procedure. Thank you very much.
Thanks very much. That was a very strong message there.
Yeah.
Thank you. That was a really clear message to be careful of bone infection, make sure that they're caught early and managed early. And as you say, function is everything to the patient. Thank you. I think that because we have run over a little bit, in the interests of time, we won't be taking questions. I'm really sorry. But if you do have any questions, please do send them in, and I will try and answer them as best as I can. Thank you very much. Thank you to the organizers, and thank you to our speakers.